Good afternoon, everyone. Hope everyone's had a good lunch and everything. What a fantastic first morning. Some really insightful speakers. Certainly I've learned something, and it's been fantastic seeing everything coming up on the chat and in the question box. And so now we've got a fantastic afternoon lined up with this session 3, about current treatment options. Just introduce the speakers for this afternoon. We have Dr. Anneke ten Brinke, who's a respiratory doctor based in the Netherlands, and she started the Severe Asthma Centre and is involved in the clinical care of patients with severe asthma, and is also involved in Sharp as a clinician and researcher there. We next then have Luciano Catani, who is a severe asthma patient advocate from Rome in Italy, and he's founder and president of the Italian Severe Asthma Association. We also have Karen van der Kastelen, who's also a severe asthma patient from Ghent in Belgium. And her sort of mission when she's well enough is to give people with severe asthma, an invisible condition, a voice. We will also hear from Professor Renaud Louis, who's head of his department of respiratory medicine at the University of Liège in Belgium, and runs a very busy clinic, which I'm sure a lot of clinicians on the line can relate to. We also have Maya Chapman, who is coming to speak to us about her experience as a patient and pregnancy. She developed severe asthma after contracting a virus when she was 21. And then finally, we'll be hearing from Rolf Wolters, who's a respiratory physician at the Dutch Asthma Centre in Davos, Switzerland. So he's an expert in alpine altitude climate treatment and supervises a team of healthcare professionals who treat patients with severe asthma there. So we've got lots of interesting speakers, a wide range of subjects. And like before, it'd be great to see you in the chat, sharing your experiences, but also in the question and answer box, because at the end of our speakers, we will be able to have some question and answers. So first off, I'll hand over to Anneke.
Thank you, Olivia. Just let me share my presentation. I hope you can all see it. Yeah. Do you see my slides? Yeah. Okay. Well, thank you, Olivia. I think we really have a very exciting meeting this day, and I'm really enjoying, and I'm particularly enjoying all the testimonies from the patient side. It's really, really, really impressive. I was asked to give a short overview of the treatment options for severe asthma. And first, we have to consider, what do we want from the treatments? And we want from treatments that people with asthma can control their symptoms, such as shortness of breath, wheezing, chest pain, cough, and that they can live a normal, active life. But we want also that the medication helps to reduce the risk for unwanted outcomes, such as that you don't have to fear for asthma attacks, for poor lung function, for treatment side effects, or even death from asthma. But as already stated this morning, it's maybe even more important to think about the personal goals of patients and to ask for it. For example, patients who want to return to work, or another telling me, I want to be able to play with my grandchildren. So, as we probably already all know, asthma is a disease of the airways, and the airways, they get smaller and smaller when they go inside the lungs, like the branches of the tree, and air goes in and air goes out. And if the asthma is good controlled, then the air can flow in easily, and there is no problem at all. And then it looks like this inside the airways. The airway wall is normal is only slightly thickened mostly. There is a normal amount of mucus. And also the muscles around the airways are relaxed and are not tightening the airways. But if asthma is uncontrolled, it's totally different. And the airways walls can be swollen and the airway can be tightened by the muscles. And at that moment, people have less air can flow in. People have experienced cough and wheezing and tightness of their chest. And they are at the risk of a serious asthma attack. And then when you look more closely at the airways, it looks like this. Then you can see that the muscles are really active and they are tightening the airways. But also the airway walls are really swollen and there is more mucus than normally. And that makes the upper part, that's what we call bronchoconstriction, this tightening of the airways. But the lower part is what we already heard this morning, is what we call airway inflammation. And this airway inflammation is really important because we've learned, scientists have investigated this airway inflammation, and they discovered that there are really different types of asthma. In some patients, there is hardly any inflammation. So this is not a problem in these patients with asthma. But in those patients, probably the muscle reactivity and the constricting or the narrowing of the airways is the main problem. Whereas in other severe asthma patients, inflammation is maybe very active and maybe a real problem. And what they also found out is that there are different causes of this airway inflammation. And the causes may be allergens, so it may be allergic asthma, but also what you heard already this morning, the eosinophil cell, so a cell in your body, may be a reason for this inflammation. Those two are called the type 2, what you heard this morning, type 2 asthma. But there are also other reasons for inflammation. Some people experience repeated infections. And it's really important for your doctor to figure out what type of asthma you have. So the doctor has to check for allergies and for the eosinophils in your blood and for recurrent infections. Because dependent on the type of asthma you have, the doctor may decide which treatment may work best for you. And how can we now prevent these symptoms and how can we prevent the airway narrowing and the airway inflammation? Well, then we have the treatment options. Of course, the first thing is what can you do without the drugs, so outside of the drugs? And there are several things. For example, to avoid the things that trigger your asthma or to work on a healthy lifestyle. But that is the topic of one of the next talks. So I won't continue on this way, but I go straight to the medical treatment. And then we will discuss the inhalers, the tablets, and also new options, the biologics and bronchial thermoplasty. And we start with the inhalers because that's the core of asthma treatments. And when you breathe in your medication, it comes directly in the airways and in the lungs where it's needed. And inhaling is really extremely safe because only a small amount of what you inhale comes in is absorbed in the lungs and comes in the total body and can give side effects. But it's only a small amount. So inhalers come in different models, as you all are aware of, and there are sprays and there are powders. But what patients need, asthma patients need, is two kinds of medications. First, you have the preventing medications, also called the controllers, and those come in two types. There is anti-inflammatory treatment, also known most of you as inhaled corticosteroids, and this is the part that helps to reduce the swelling and the mucus. But there's also another component, and that's the bronchodilator medicine. That's what relaxes the muscle around the airways. And those two controllers mostly are delivered in one and the same inhaler. But next to this controllers preventing medication, you also, of course, need a quick reliever that may stop acute symptoms and that may help to prevent an asthma attack. But what if your asthma is not controlled despite the proper use of these inhalers, as is the case in many of the severe asthma patients? Well, then there are multiple options. And then I come back to what I said. It's really important to know which type of asthma you have, because that helps your doctor to decide which will work best for you. And of course, you can increase the dose of your inhaler, or an extra controller can be added. For example, leukotriene modifiers, they are known with the names of Montelukast, Sevelokast, or Xyluten, or theophylline tablets. And maybe some of you will recognize these names. But depending if you have allergic asthma, your doctor may add anti-allergy medication, for example, antihistamine tablets, nasal spray, or immune therapy. If you have high levels of the eosinophils, extra inhaled corticosteroids may be added. Or if you are a person with repeated infections, it may be considered to add low-dose antibiotics, azithromycin tablets, also already mentioned this morning. But also, some patients, there is no inflammation, but there is a problem with the muscle tightness, and then you may add an extra bronchodilator such as tiotropium. And it's really important that it's tailored, and it's an individual choice for every patient. But in severe asthma, despite all these treatment options, that may not be enough or not be available to control your disease, and even an asthma attack may occur. And in that case, then the doctor will prescribe you possibly corticosteroids, and this is mostly prednisone or prednisolone, and it can be given in tablets or in injections. And in many patients with asthma, prednisone works very well. Not in all patients, but in many it does. But in severe asthma, many patients need more courses of prednisone a year. And sometimes it may be decided not to continue taking prednisone, not only for courses, but also on a daily basis to control your disease. And then I think of one of my patients. She told me, well, prednisone, I need them so much when things go bad. At least my asthma will calm down a bit, but it's also such shitty stuff because I have so many side effects from it. And I remember the discussion this morning. I think many of you will recognize this. And indeed, prednisolone may be really effective in asthma and also life-saving sometimes. And if you take it for a short period, there is only a few side effects. But when you need them often, we really have to be aware and afraid of the side effects, such as weight gain, osteoporosis, the thinning of your skin, high blood pressure, or high sugar levels. There are plenty of side effects. And but fortunately, there are new treatment options for a subgroup of patients with severe asthma. And this is there are new medicines developed. They are very specialist and targeted treatment, and they're much better, I think, than all those prednisone tablets. And these are called biologics, or with another name, monoclonal antibodies. And they're not available for every patient. They're really expensive also. But these biologics, each of them targets a specific part of your immune system, and thereby blocking the processes that activate the airway inflammation. And they mainly work on inflammation that's caused by allergies or by eosinophils. So it's really, there it is, yeah. Currently, there are 6 biologics approved for asthma. And the first 5 here, they can be used in patients with allergic asthma or with eosinophilic asthma. And the newest is tezepelumab. It's now available in a few countries, but it will probably increase the next years. Then this is the first one that's not restricted to one type of asthma, but can also be used in patients with severe asthma who are not allergic or who don't have eosinophilic inflammation. And these biologics can be really life-changing for many, but unfortunately not for all, for many patients with severe asthma. they can improve the asthma control, they can reduce the prednisolone that the patient needs, they can reduce the risk of an asthma attack. And it's really, it's very good to see how effective it may be for a subset or a large subset of patients. And well, when citing again the same lady, she said, oh, with a biologic, it's kept me out of the hospital. The number of attacks is decreased. I have so much more energy. I even started a new job, and the quality of my life is so much better. So for many of them, it's the patients with a specific type of asthma, this is a really, really important improvement, but unfortunately not for all. This treatment, well, this is given by injection and every 2 to 8 weeks, depending on the specific medication. But of course, like every medicine, there are also side effects. And some common side effects, well, every 1 in 10 patients reports something like this, is rather mild. It's a headache or a sore throat or soreness at the injection site, mostly 1, sometimes 2 days after the injection. But the most severe side effect is a severe allergic reaction. We call it anaphylaxis. And for that reason, it may occur. For that reason, everybody who starts with this biological treatment in a hospital who has to get information, what are the symptoms to look for, and what is it, when should I ask help, and when should I warn a doctor? And unfortunately, this is a really rare side effect, about 1 in 1,000 patients. And in our hospital, we did not have this side effects yet, and I hope it won't happen. I said this is life-changing and very successful for many patients, but not for all. And why not for all? And that's for several reasons. And in some countries, these biologics are not available, and it's mostly due to the cost. There are also countries where patients have to pay part of the bill, and it's really expensive. So that may be a reason that you can't use it yet, hopefully in the future. There's also a group of patients, if you may have a type of asthma for which there are no biologics, or you may have the right type of asthma and you started a biologic and you may even tried more of them, but they still don't work. So again, this may be really disappointing. And finally, there are some patients who do benefit from it, but they have serious side effects, so have to stop them. Is there then anything else? Well, yes, there is. It's not a drug, to be honest. It's also not available in every country, but it is bronchial thermoplasty. And bronchial thermoplasty is a surgical technique that helps to open the airways. And patients go under anesthesia, and that's the procedure. And then a thin tube, it's a flexible tube, will enter and will pass through your throat into the airways. And then gentle heat is applied in the airways, and it aims to shrink some of the muscle tissue that is around your airways, and that tightens during an asthma attack. And you can see the example. Here is the muscle mass around your open airway in patients with asthma. This thickens. If you have an asthma attack, it's even more thickened. But after this therapy, you can see it's reduced. The airway smooth muscle is reduced. So it's not constricting, not narrowing as much as it did before. And in some patients, this really improves the quality of life, and it reduces also the asthma attacks. But it's still a rather new technique, and we are not yet sure what are the long-term effects. And also, it's not clear yet which patient will benefit most. So more research is necessary. And that brings me to my takeaway slide, and that's, well, asthma is a disease in which the airways get swollen and narrowed, and making it hard to breathe. Unfortunately, there is no cure at the moment, but there is multiple treatment options or controllers and relievers. If you have severe asthma, you often need multiple treatment options. There are also some new ones available, biologics and bronchial thermoplasty, but it's really important that it's individualized. Every patient should have his own treatment program. And so I really advise to discuss with your doctor what's best for you. Thank you very much.
Thank you so much, Annika. It was a fantastic talk. So don't forget to put your questions into the Q&A box for Annika at the end, for the end of this session. Next, we're going to come on to Luciano and Karen, who have both prepared videos for us to hear their experience as patients. Is it possible to play them, please?
Cioè io avevo una media di 10, 12, 13 esacerbazioni all'anno. La mia vita era fatta di 15-20 giorni di antibiotico e cortisone, una settimana di sollievo e un'altra settimana in cui ricominciava una piccola tosse e quindi da lì 1000 visite da diversi medici, diversi specialisti, esami, CT scan. Stavo sempre in casa, chiuso, continuamente ammalato o a letto, continuamente con prendere delle medicine, una forte depressione. La prima reazione è stato sollievo, è stato finalmente sappiamo cos'è, finalmente sappiamo come affrontarla. Sollievo e soprattutto determinazione a risolvere almeno i sintomi più gravi e a smettere di subire o di prendere il cortisone orale. Comunque abbiamo provato il primo prodotto biologico, anticorpo monoclonale, che era specializzato soprattutto per le allergie e non trattandosi di una asma grave a base allergica, evidentemente aveva una funzionalità molto limitata. Ha ridotto sì il numero delle esacerbazioni, ha evitato i ricoveri in pronto soccorso, ma non ha risolto totalmente. Siamo andati avanti 1 anno e mezzo, 2 anni con questo farmaco, prima che uscissero dei nuovi prodotti biologici, monoclonali antibiotici, che avevano delle funzionalità più specialistiche. Uno era, soprattutto erano antagonisti delle ipereosinofilie entrambi, con efficacia maggiore o minore, dipende. E quindi io sono passato direttamente a quello più forte. Il sollievo è stato immediato, cioè il numero delle esacerbazioni si è ridotto immediatamente da 12-13 a 2-3 al massimo durante l'anno. Non prendo steroidi più orali, effetti collaterali non ne ho. non conosciamo i risultati a lungo termine. L'unico side effect che ha avuto è che io, quando finalmente ho potuto riprendere a viaggiare per turismo,
ik heb al astma zolang ik mij kan herinneren. Toen ik een jaar of 2 was, deed ik de ene infectie na de andere. Mijn moeder ging naar de kinderarts in de buurt, die door iedereen aangeprezen werd als de beste dokter. Maar die zei elke keer dat het maar een longinfectie was en die schreef antibiotica voor. En ik werd eigenlijk niet beter. En zelfs toen ik zo klein was, wilde ik niet meer terug naar die dokter. Dus toen daar een nieuwe huisarts in de straat van mijn ouders kwam wonen, heeft mijn moeder mij opgepakt en is naar hem gegaan. Ik was toen een jaar of 2. En blijkbaar heeft hij wel al beslist en gezien dat ik astma had. En hij heeft mij toen relatief goed kunnen behandelen. Maar tegen dat ik 4 à 5 jaar oud was, heeft hij toch beslist om mij door te sturen naar een specialist. En het is pas die arts die eigenlijk geconstateerd heeft dat ik een zeer ernstige vorm van astma had. Allergisch astma. De specialist waarbij ik terecht kwam was echt wel een goede arts. En tegen dat ik een jaar of 8 à 9 was, heeft hij mij ingeschreven in een onderzoek voor de eerste cortisonepuffers. En daarvan bleek dat ze wel aan het werken waren. En dan heeft hij kunnen zorgen dat ik die medicatie toch kon blijven nemen, ondanks dat het nog niet op de markt was. Dat was ook een periode dat ik algemeen beter was. En ja, gewoon door te bewegen ging er veel gewicht af, kwam ik veel spieren bij. En daarmee ben ik toch een tijd beter geweest. En dan ben ik opnieuw naar de longarts gegaan, die heeft gebeld met de endocrinoloog. Dan hebben ze al mijn bloedresultaten nog eens bekeken. En wat bleek, dat ik nog niets van cortisone in mijn bloed had. Mijn lichaam maakte dus zelf geen cortisone meer aan. Sindsdien is er dus de ziekte van Addison bij mij vastgesteld. En dat betekent dat je bijnieren stoppen met cortisone maken. Op het vlak van biologicals moet ik ook echt wel even vernoemen dat ik toch echt wel het gevoel heb, moest ik ze vroeger hebben kunnen krijgen, dat dat een enorm verschil had gemaakt op mijn lichaam. Door al die jaren, al die infecties en astmacrisissen na elkaar. Op den duur heb je zo het gevoel dat je zo'n speciaal geval bent, dat je nergens meer in past. En voor de ziekte van Addison zeggen ze zelfs letterlijk dat je je eigen dokter bent. En eerlijk gezegd, als ernstig astmapatiënt is dat ook een stukje zo. En ja, op een bepaalde manier moet je het zelf allemaal maar zien op te lossen. En dat is wel heel zwaar om te dragen.
Non c'è abbastanza conoscenza. Nel medico generico, il medico di famiglia o anche negli ospedali, gli stessi pneumologi che non sono nei centri specializzati dove hai la possibilità di fare analisi multidisciplinari.
Ik ben eigenlijk op een bepaald punt gekomen dat de huisarts niet veel voor mij meer kan doen. Het zou toch mooi zijn, moesten ze gewoon zeggen, die doelgroep, je mag kiezen tussen die medicatie. Maar ja, kijk, ik heb wel geleerd, als je zo'n speciaal geval bent, dan moet je voor alles vechten. Ja, een mens kan alleen maar dromen, hè.
There were two very powerful videos from both Karen and Luciano giving their perspective of as a patient of treatments. So what we're going to come on to next is invite Renaud to speak to us about how to choose the right treatment.
Hello, do you hear me? Do you see the slides?
Yes, you can hear you, and but the slides are like 6 on the page just now.
Yes, okay, yes. So thanks, Olivia. Thanks for the invitation to Sharp and the ELF to talk about which is the best treatment for the patient, which is obviously a difficult question. This is the presentation outline. These are the different points I would like to share with you in these next 20 minutes. So I would like first to start with reminding you, for the youngest in the audience, that we have made tremendous progress in asthma treatment over the last 20 years. And since the discovery of inhaled corticosteroids, we saw really a dramatic change in the asthma mortality. And these are two important slides, I believe. One from SUISA. This is a pharmacoepidemiological study in Canada showing the inverse relationship between the cell of inhaled corticosteroids and the mortality. And on the right-hand side, you see in different European countries, you can see here the change in mortality since the end of last century until 2010, but this is the same in 2020. So there is a general decrease in asthma mortality. So we have never to forget that we have made dramatic progress thanks to ICS. However, you know that there are lots of patients with difficult asthma, approximately 20%, as reminded by Ramesh this morning. And in these patients, there have been several, I think, paper and several scientific reports pointing out that the adherence may be sometimes a bit not satisfactory. And it is estimated that adherence in asthmatics, and this is almost the same in severe asthmatics, which may be surprising, is around between 30 and 70% according to the study. We also know that low education level and poor patient-clinician communication is a factor of low adherence. So what does it mean, low adherence? It may mean incorrect inhaler technique. It may mean inhaler type which is not suitable for the patients because insufficient force in inspiratory flow, for instance. But it also may mean reducing medication when feeling well, and the patient is not observant to the regimen which was prescribed by the doctor. So what can do the doctor for that? This is a key question that really is around since, I would say, 30 years. I think it's to check handling and to talk to the patients. I will come back to that later. Please take the time to talk with the patient, dedicate time to the patient. So just a quick reminder that difficult to treat asthma is something like 17%, and real severe asthmatics that is resistant to treatment is around 5% of all asthmatic patients. So very important to realize also that, and it's important to choose the treatment, that there is a huge heterogeneity among asthmatics, also among severe asthmatics, really huge heterogeneity in the phenotype. And this is linked to the fact that the asthma pathophysiology is extremely complex, implicating, you know, immunity, different type of inflammation, microbiome, bronchial hyperresponsiveness, which is a sign of twitchiness of the airways, degree of airway obstruction, and all these features actually determine what we call the phenotype of your disease, so the type of your disease. On the left-hand side, just to tell you that it's very complex. When you look in details at the mechanism, the molecular and the cellular mechanism in asthma, it's very complex. But now, as a simplification, we tend to use two categories, T2 high and T2 low. And when you have a T2 high asthma, you may have an allergic component, but you may also have T2 high without any allergic component. And these T2 high are clearly the most frequent phenotype in severe asthmatic. It has been said. This is, I think, very clear now. But you may have sometimes T2 low patients. And in these patients, you may think of a role of chronic infection or also pollutant exposure. These are important factors that may cause severe asthma in T2 low patient. Biologics is essentially for T2 high right now. I will come back to that later. So the thick trait, the thick line here is to just remind you that T2 high is the most predominant phenotype in severe asthmatics. So the key question is how to choose the right biologics. But the first answer is you have to choose the biologic which is available in your country. And you see from this recent survey that we have undertaken with the SHARP, that in some country you cannot only have omalizumab. Omalizumab is available in all countries in Europe. But you see that for other, and especially for dupilumab, there are still countries that don't have this medication. So omalizumab in every country, mepolizumab, benralizumab, and Resli in most of the country in Europe. But dupilumab, there are some hole in country. And in my country, we don't have dupilumab yet, for instance. So because you have understood now that asthma is quite heterogeneous, even among a severe asthmatic patient, we have to phenotype the patient and for choosing the right treatment. And to phenotype the patient, we need to perform some tests. And I listed here on the left the tests that are really necessary to phenotype the disease. You need blood sampling. You need spirometry, which is a lung function test where you are assessed for your expiratory flow rate. You need FeNO measurement. And in some centers, when it is available, you need also a sputum induction to look at the different cell type in sputum. And based on these analyses, some experts may derive algorithm that will drive you to the choice of the best treatment. And just being without any going into much detail, if you have an allergic component, you may benefit from malizumab or malizumab, for instance, that is anti-IgE. If you have an intense eosinophilic inflammation, you probably will benefit from a treatment targeting eosinophils, and these are anti-IL-5 like mepolizumab or benralizumab. And you have heard with Anneke about tezepelumab, which will become available hopefully during this year. Tezepelumab might be also efficient in non-T2 asthmatics, but you have to understand that to choose the right biologics, we need to phenotype the disease. We also need to take into account the comorbidities, because if you have, for instance, chronic sinusitis with nasal polyposis, we know that drugs like omalizumab, mepolizumab, and dupilumab may be efficient not only on your asthma, but also on your ENT disease. If you have atopic dermatitis, dupilumab is extremely efficient to control atopic dermatitis as long as your asthma. So depending on your comorbidities, the doctor will probably propose you different type of biologics. So with the SHARP survey, we have seen that there is huge heterogeneity between countries in the criteria that the public health authority have set to reimburse the drug. These drugs are costly, and you can only use them if they are reimbursed. And this is also a major factor that will determine which kind of drug you are able to use in your country. So the exacerbation rate varies from 2 to 4. You look at FEV1% predicted. It's sometimes less than 80% predicted, but it's not always like in every country. The levels of IgE are variables. The level of blood eosinophils. Some countries need a FeNO value to reimburse dupilumab. And sputum eosinophils, sometimes in 2 countries in Europe, was considered as a criterion. So great heterogeneity there also. So what can you expect from a treatment with biologics? This is key for you. And the first thing is reduction in exacerbation. All these trials, they have validated these drugs, have taken as a major outcome the exacerbation rate. And I would like just to take a few minutes to tell you what is an exacerbation. This is so important. This is a concept which was developed at the end of past century. An exacerbation is a clinical state in which there is a clinical deterioration of the patient in terms of symptoms, in terms of lung function, with an increased impairment in lung function, and also an increase in consumption of reliever medication. And despite the increased consumption of reliever medication, Ventolin, for instance, there is still a severe impairment in lung function. And in this case, the only thing that the doctor can do to help you to overpass this difficult time is to give you systemic corticosteroids. So this is the definition of what we call an exacerbation in asthma. And with the biologics, in clinical randomized study, we can reduce this worrying state of the disease by 50%. If you go to real life now, you can reduce that by more than 80, 90%, because you have also the placebo effect in real life. So when a patient is treated with biologic, there is a considerable reduction in the exacerbation rate. But it's not only exacerbation, this is also really severe exacerbation that lead a patient to hospital. It has been demonstrated here with mepolizumab in drug trials, and in, sorry, here it's not mepolizumab, it's omalizumab in a real life French study where there is a 75% reduction in hospitalization for the asthmatics when they are treated with the biologics. Exacerbation is one thing. The other thing is the quality of life. And it is extremely important for you because it's a patient-reported outcome. This is self-administered questionnaire. So this is the way the patients assess the disease himself. And it has been clearly demonstrated that these biologics, mepolizumab on the left here, benralizumab on the right, that these biologics may increase clearly the quality of life of the patient. So it means that the patient feels that he's better. It's not only looking at improvement in the lung function, or even at reducing the exacerbation or FeNO or blood eosinophils. It's looking at what the patient feels, and the patient feels clearly better when he's treated by the treatment. And Anneke used the word life-changing, and I think it's perfectly true. The patient come back to you. You don't need, 100 or 1,000 patients to be convinced. Sit in front of you and tell you, doctor, my life has changed. This is clear. And another important point is the reduction of oral corticosteroids. So for those patients who need OCS on top of ICS high-dose LABA, these biologics may also be able to reduce the dose of OCS. And it's extremely important because OCS is associated with a lot of side effects. Also interesting probably is that once the patient is well controlled with the biologic that it may happen, you can also reduce the background medication. And I'm thinking especially to the dose of ICS. And I think it's interesting to try to decrease the dose of ICS of the patients when they are stabilized by the biologics. So there is a recent concept which has been put forward with the biologic treatment. This is the concept of remission. And although there is not a general consensus about what remission means for everybody, I think probably the consensus will be that remission is no use of OCS, no exacerbation, and a good asthma control over a long time period, something like 12 months, for instance. And if you apply this definition, and if you look at all the data coming from the randomized control trial, it appears that something like between 20 and 40% of the patients are able to achieve remission in their asthma, which is remarkable because these patients had a bit miserable life before. And the fact that something like between 20 and 40%, depending on the definition, are able to be in remission, I think it's a remarkable results. Another goal that might be interesting also is to stop lung function decline. We don't have much evidence for that, to be honest. This is just a study which has been recently published coming from the Belgian Severe Asthma Registry, and suggesting that those patients who have received anti-IL-5 have actually stopped their lung function decline over time. There was something like, if I remember well, 12 months between the two visits, and we looked at the post-bronchodilation FEV1, which is, if you wish, the best lung function that you can achieve. And those patients that had received anti-IL-5 over time seems to have a slowdown, and even in our study, a stop in the lung function decline over time. Is it safe? This is a key issue, obviously. There are some reports, because these are quite recent treatment, and to be honest, there is no bad signals that has come so far from both randomized controlled trials and also extension studies with these different biologics. So it means that you can target, very specific metabolic pathway without really compromising the immunity of the patient so far. Another key question that the patients often ask us, how long should I be treated, doctor? Actually, we don't know really. We start having some evidence now that if we stop the treatment, once the patient is well controlled, it might be different if the patients have been treated with anti-IL-5 or with anti-IgE. For those who were treated with anti-IL-5, after a few months, there is a tendency for the disease to recur. While for those who were well controlled with anti-IgE, actually the recurrence of the disease activity may be much slower to appear. But I think we need more data on that point. Why and when to switch? Why to switch if the patient is not satisfied by the response to the treatment? This is a survey from the SHARP asking what the doctor are expecting from the treatment. And you have the list here. This is the reduction in exacerbation, the reduction in the use of OCS, also the improvement in quality of life, etc. But we don't know inquiry survey yet about what the patient would like to achieve with these. And this is an idea for a new prospective trials probably in the future. But anyway, in any case, I think if we decide to switch, it must be a shared decision-making between the patient and the physician. I had just an example. Yesterday, I had a patient who had been treated 6 years with mepolizumab. She was fine. And we decided together to try to stop the treatment. I told her, I'm not sure that your disease is not going to recur, but over the last 5 years, she had never taken oral steroids anymore. She had a normal lung function. She had a good asthma control test. So we decided to stop, and we will see what will happen. What about pregnancy? This is just a few words of pregnancy, because to be honest, there are not too many things on pregnancy. This is just a recent review if you are interested. I think we can say that omalizumab is probably the best studied with reassuring available safety data during pregnancy. For other biologics, we have very, very little evidence. So probably it's best not to start the treatment during the pregnancy, but if the patient is already treated and if she is well controlled by the biologics, I think it's probably reasonable to continue the treatment, because an asthma which is not controlled during a pregnancy may be also something which is risky for the mother and the child. So what to do with those who are not eligible? These T2 low, which are much rarer. I think it has been already said, azithromycin may be tried, LAMA, but to be honest, LAMA has no real marked impact on what the patient perceives, and no real strong impact on exacerbation, neither. LTRA, there are absolutely no data in the literature on that point. We, as a doctor, we used to do that, but we don't know whether it is useful. Stepping down ICS, I think it might be interesting. If you are T2 low, non-eosinophilic asthma, we have made a study looking at this special point, and we found that in some patients, stepping down ICS may improve asthma quality of life, and reducing the burden of the drug may be sometimes interesting.
Renaud, just 1 minute.
Yes, I think I cannot control anymore. Sorry, my screen. I'm stuck. Could you yes, okay. There are not pharmacological treatments. This is the thermoplasty that's been always said, but this is costly, and it's not performed in many centers. It's not performed in my country, as in, for instance. And I would like to conclude with these important points. This is the dedicated severe asthma services. And this is a UK study published a few years ago looking at severe asthmatic patients and showing the dramatic improvement in asthma quality of life and asthma control at the second visit, although there was no change in treatment, And we found the same in a recent study in more than 1,000 patients that were selected. Asthma quality of life may improve at the second visit without any necessary increase in the drug, because you see that according to the different scenario, sometimes in stepping down ICS, sometimes in stopping OCS, you have improvement in quality of life. And to conclude, I would like to, because I know there will be a lecture on the other part on drugs, you see that most asthmatics are overweight, and some are obese. And I think that physical exercise is certainly something which is important to consider in the future. And we have recently performed a randomized study. This is just interim analysis, showing that regular exercise under supervision with a sport coach improved dramatically the asthma control and the quality of life of the patients. And we hope to be able to submit this study during this year. But I think we were very impressed by the improvement in the prompts of the patients. So I think there was a poll now, which is Courtney. I suppose this is a bit scenario to conclude, and you are asked what you can expect from the treatment with the biologics. So I suppose you are voting no.
Yeah, so people will just be doing the vote on the poll, and then we will get the result of that, and then we will need to move on to the next speaker.
Yeah, I am happy with the answer. These are the answer that I was expecting. Yes, absolutely. Reduction in exacerbation and improvement in quality of life. You are not changing the allergic status by giving anti-IL-5. You are not curing asthma neither. You can put asthma in remission, but it's different from cure. Cure is something which would imply that you are fine without any drugs. I think it's a bit, we are not there yet, clearly.
Thank you so much, Renaud, for speaking with us. I'm now going to be joined on screen by Maya, who's going to speak to us about her experience of living with severe asthma and pregnancy.
Hi. Hey, you ready for me?
Yes, I think we just I will try and if Renaud could stop sharing his screen.
Yeah, but I have no control anymore from my, I'm sorry, from my computer. I cannot move the slide.
Okay, we'll work it out, but yes, we'll
Could you
head on, Maya, okay?
Yeah, no problem. I'm not sharing anything. I just want to chat to people. So I was a bit late to the asthma party, I suppose. I am from an era where you didn't get the MMR because of autism. So when I turned 21, I then got mumps. And from that day, I've had severe asthma, literally like a switch overnight. And I was diagnosed in October 2006 with non-atopic eosinophilic asthma. And I started a daily dose of 40 milligrams of steroids. And I had that for a very long time. So I gained 10 stone in just over 10 years. My teeth are awful because of that. I'm sure there's some sort of damage to my bones. And my asthma was that bad, but I'm adamant it had something to do with like hormones, because every single month when my menstrual cycle would come, literally to the day, I'd have a really bad exasperation and need steroids. And I was just exhausted. I'd react to everything from dry food, like toast, the smell of the laundry coming out the washing machine, changing temperatures, even opening the freezer. And it didn't matter what season it was, I'd react, whether it's cold in the winter or lovely and hot in the summer, I'd then react to pollen. So I stopped going out. I developed cough syncope, where I can cough, and there's a certain kind of cough that I have, and I pass out, and my poor family have to deal with that, or did. I then had physio multiple times a day. I would go through 8 salbutamol inhalers a month, as well as a nebulizer. I lost my job. I missed out on so much family time. By that point, I'd had a little boy, and I was just a prisoner in my own body. And then in 2012, I became pregnant again. And it was my first pregnancy with asthma, and it was horrendous. I couldn't walk. I was on oxygen constantly. My baby was delivered early at 7 weeks, but weighed nearly 4 kilograms. She was massive. And I put that totally down to the steroids. Because there may not be a link, but for me, I think there was. When Molly was born, she's now an asthmatic, and quite not a severe asthmatic, but she does really struggle, and I've really got to monitor her. And for me, that pregnancy was really, really difficult. I lived in the middle of nowhere in a little village in Wales, and my local hospital had shut their A&E. So for my daughter and my health, I decided to move, because the nearest hospital was 45, 50 miles away. So in 2014, I moved to South England. I went to see a local consultant who told me that I was far too sick to even have me on his books. So he referred me to the team in Southampton, and they were amazing. They listened to me. I felt like I was controlling my asthma, because they gave me all the information, even if they thought I didn't really need to know it. It did make me laugh when I first went. I blew into this machine, not knowing what it was, and I was quite chuffed. My reading was over 300, and apparently it's meant to be less than 25. And my pheno ever since has always been higher than about 200, but I can deal with that. I normally break it, so it's quite nice having a lower one now. Then I started the meprolizumab, and it worked. It was really good. I could breathe, but I was in bed exhausted all the time. The side effects from it were really difficult. I have ME, and it just made that so much worse. I stopped in 2017 when I became pregnant again, and my asthma pretty much disappeared. just randomly, it just disappeared. It went into remission. I felt amazing. I was still on the maintenance steroids, but I was stable. I still had gestational diabetes with this baby as well. And due to having previous cesareans and the worry of my asthma, my baby was delivered at 5 weeks early. And again, he was quite a big baby at 3.8 kilograms. He is also asthmatic, but he's not severe. He only really needs an inhaler during the winter. But as soon as my son was born in 2017, my asthma literally came flooding back almost instantly. I held off going back onto any biological for 6 months because I wanted to breastfeed, but I just had to stop. When he was 6 months old in June 2018, I restarted, but I just couldn't deal with it. The side effects were just too much, so I stopped. In December 2019, I then started benralizumab, and I did have side effects to begin with. It's normally skin related. I'd come up in hives all over my body. I had a horrendous headache and a sore throat, but I felt amazing. And on the 9th of July, 2020, and I remember the date, it was a Thursday, I took my last ever dose of steroids. I'm now on day 926 without maintenance steroids. Everything in my life has improved. My mood, my skin, my energy levels, and I've lost 6 stone of weight. So I decided that I wanted to have one last baby. I looked online. There was really limited information, but I searched and I had to translate some information because it was in a different language. I discussed it with the team, just how important it was for me to be able to be in control of my asthma and the treatment I was getting, because nobody knows their body like yourself. So we decided to stop in February 2021. I became pregnant. By April, I was going downhill and I was on the verge of needing steroids. So the conversation was whether I went back on the maintenance steroids or whether I restarted benralizumab. And I had all the risks explained to me. We went through everything. My asthma specialist nurse is amazing. I'm sure she wanted to throttle me most of the time because I asked really stupid questions and I wanted to know the finer details of everything. But it was a joint decision and it was an informed decision that I wanted to restart my benralizumab. And so in April 2021, I did. I had no gestational diabetes in this pregnancy. I was monitored, but I had no diabetes at all. My baby arrived in December 2021. She wasn't even that big. She was just 3 kilograms. She has no signs whatsoever of having asthma, even when we all got COVID. She was born with no eosinophils, but she is now in the normal range and is really happy, really healthy. She's absolutely crazy, but she's fine. My life now, I work full time. I own my own business as well. I'm a mum again, not just because I have children, but because I can actually do stuff with them. I've got 4 of my own, and then I have 2 stepchildren, so our house is pretty mental. Benralizumab has literally changed my life, and my quality of life is amazing. I inject every 8 weeks. I used to be terrified of injections, but I will happily do it whenever I need to. And I've even had COVID 3 times, and I'm still here. And I wouldn't have been able to do it without the injection. I actually have one with me because I've got to do it next week. And I love having a delivery. It sounds silly, but it really has changed my life. And everything is positive. And I love it. It's quite strange to say that, but I do. I don't really have anything else to add. But
I think Maya, what you've explained is how you built the relationship with your care team to discuss your options, change your medications, to do what was best for you as a patient, which is really key, which is what Annika and Renaud and the others have spoken about. So thank you so much for
no worries. Thank you very much for having me.
No, it's our pleasure. It's fantastic to hear patient stories. What I'm going to do now is invite Rolf to come and, for our final speaker for this session, to come and speak to us. Rolf.
Thank you. Yeah,
Welcome.
thank you, Olivia. Yeah, as you said, I'm the final speaker of this session. I'll start sharing my screen so you can see the presentation I prepared. Previous speakers in this session have talked about the drugs you can use for asthma, and I'm tasked to speak to you about, apart from the drugs, what else is there? My name is Rolf Wolters. I'm a Dutch pulmonologist, and I work in Switzerland in the Dutch Asthma Center we have here in Davos, where we offer treatment to asthma patients in the form of rehabilitation in mountain climate. As I said, the Dutch Asthma Center in Davos, as we call it, het Nederlands Astma Centrum Davos, is a center located in the eastern part of Switzerland, Davos. And that area is known for its alpine climate, a clean environment, clean mountain air. And historically, it has been known for many rehabilitation clinics, other than asthma as well. And other countries also have clinics in the area here. There are unique environmental factors, increased air quality, lower amount of pollution, lower amount of allergens and fungus, and also the air density is lower here. The position we have in the Dutch healthcare system is we are one of 6 centers that offer pulmonary rehabilitation. However, we are the only one who are located outside the Netherlands and in Switzerland. The center is 125 years old, and since 1996 we offer treatment exclusively to asthma patients. We have 20 beds, so 20 patients at a given time are in the center, and with the course duration of around 8 to 10 weeks, we offer treatment to around 130 patients per year. And patients are in the center for 8 to 10 weeks straight, 24/7. And as I'll speak to you about along in this presentation, that offers a unique situation where you can observe what is happening and how patients deal with their asthma, what they're doing in coping and self-management strategies. There are also other countries in Europe that offer similar treatments. For instance, clinics from Germany, France, Italy, Portugal that offer treatment in an alpine altitude climate. However, I can't tell you a lot about the specifics about those clinics. But for the viewers from different countries, it's good to speak with your own physician and see what kind of options you have in your country for treatment in mountain air alpine climate. The treatment stands on three pillars, basically. We treat people with severe uncontrolled asthma with a high disease burden and high level of medication dosage. And the first pillar is something I talked about already, is the alpine climate, low stimulus environment. The second pillar is a team of asthma specialists, expertise in asthma treatment in a multidisciplinary approach, doctors, psychologists, physical therapists, dietitians. And as a team, we work together to highlight all the aspects of basically the disease that asthma patients have to deal with on a daily basis. The third pillar is also very important, and it's time away from your own environment. In your own environment, there's a lot of things that you have to do, a lot of stress that's happening. And it's key to lift a patient out of that environment. In the Netherlands, if you look at all patients, yeah?
Sorry, just to let you know, I'm controlling your slides. Oh. So you tell me when to advance, okay? Thank you.
Okay. In the Netherlands, we have around 630,000 people with asthma. And I think a previous speaker has spoken about this as well, that a lot of patients with asthma are relatively easy to control. But if you have difficult to control asthma, it's like 20% of the patients. And if you if you highlight all the treatable traits and optimize everything, then you have around 4% where you call it severe asthma. this is something that the previous speaker also highlighted a lot. So you can do the next slide if you will, Courtney. Or I can do it, yeah. High disease burden, a lot of symptoms, mostly at night, severely reduced quality of life, and also increased consumption of healthcare systems, and sometimes also admission to the ICU, something you want to avoid at all costs. Why treatment in alpine climate? Alpine climate as a medicine, as I said, it has unique environmental factors. However, it's still unclear which factors are at play, which factor plays which part. We do know now that staying in mountains has an effect on the immune system. It decreases inflammation in the airways, and you can also measure a decrease of the asthma parameters in blood and expired air, such as the eosinophils and the nitric oxide. And there are certain proteins that play a key part in asthma inflammation that decrease as well when you're in alpine climate. Our team of researchers has collaborated with the European Academy of Allergy and Clinical Immunology to create a task force paper to highlight these aspects. This slide that you're seeing now highlights some of the things that are fairly well known. A decrease in pollen, a decrease in fungus, also the house dust mite, which is a lot lower here in alpine air, and that has a beneficial effect on asthma control. This slide is a little less well known. Apparently, there is a lot that's happening with alpine air, with a lower amount of oxygen in the air, which has an effect on a lot of things in the body. Things that we're still not entirely sure about, and research is still being performed. But staying in clean air environment has a lot of effect on the body, basically. And what you can see for asthma is that the lung function can increase. You can decrease the amount of inflammation, which translates into a decreased amount of medication that you will need. You can increase your physical fitness and train your muscles in this environment, because asthma is much less of a factor here, because it's getting controlled by the environment, basically. This slide is very important. Historically, it was thought to be known that you had to have allergic asthma to have an effect in the mountains. But what we're able to assess is that if you have other types of asthma, treatment in alpine climate can also have a beneficial effect. What you can see here is the two questionnaires that are fairly often used in asthma measuring. The ACQ, this Asthma Control Questionnaire, and the AQLQ, the Asthma Quality of Life Questionnaire. And you can see that the dotted line, the allergic asthma line, has a larger effect. However, the non-allergic asthma line also has an effect. So nowadays we basically treat all phenotypes of asthma in alpine air. The key factor is you have to have a type of asthma that is difficult to control in your own environment. That's basically the main factor to determine if you should engage in these kinds of rehabilitation sessions. The long-term effect has also been studied. What you can see here is when patients are discharged, they have an increased effect on the ACQ and AQLQ, and that effect, they can retain that effect for up to 12 months and sometimes even longer. Like I said, we have a team of healthcare specialists specialized in treatments of severe asthma, and the goals of treatment is to make asthma manageable again in the low stimulus environment. You can increase your endurance and muscles and exercise to increase muscle strength, and also you can decrease the amount of medication that you need to control your asthma. like I said, the observation is a key factor. We have patients here for 8 to 10 weeks straight, and it often leads to new insights, things that patients do in the coping and the self-management. And these are things that we can give back to the patient and also to the colleagues in the Netherlands to use these factors in the long term when patients are back at home. The treatment program is an individual program based on assessment and personal goals. In this treatment program, we have an intensive exercise program with a fitness center, a swimming pool with no chloride, and outdoor activities, mainly walking in mountain air, alongside a couple of our specialists to support. Also, we have individual consults with different practitioners, doctors, psychologists, etc. One of the strengths of our team is that we are a relatively small team with short lines of communication, and they start with the entire team, where we assess every patient from day to day with the entire team. You can see in this slide a link to a video I highly recommend watching it. In 15 minutes, a 2-minute video is quite a lot of time, so watch it in your own time. But it's a 2-minute video that highlights what we do in the center, also with images of what the treatment looks like. Highly recommended. Here you can see the team of experts that we have in the center. Like I said, pulmonologists, psychologists, the team of exercise and physical therapists, but also dietitians, researchers, and also the medical social worker who can help with how to basically how to how can I say that when at home. How to retain everything you learned and use that in the situation when you are at home again. Concluding, well, we're treating in the alpine air a population of people with severely uncontrolled asthma, every type. That's very important, and there's increasingly scientific evidence for a good outcome in asthma treatment for over 12 months. Increasing knowledge about the effects on the immune system. And here we treat you with a team of specialists, specialized in severe asthma treatment. The diagnostics we do here, we can use to supplement your own physician at home, and gain a higher insight in the type of asthma you have. Also, decreasing medication is something you can do in mountain air, and exercise training becomes possible again, so the patient regains control of asthma again. I thank you for your time. I think I was within 15 minutes. I hope you learned something from this presentation.
Yeah, thank you so much for that, Rolf. It's been really insightful, and it makes me sort of want to take a trip out to Davos. So now going to be joined by the other speakers for question and answer session. Just wait for everyone to appear. There's been quite a few questions put into the question box, and actually I've seen some of you have sort of put your name next to some. Annika, so there's a question that you're wanting to answer about. Hilary has put that there's a wide range of reasons patients react differently to biologics, genetics, environment, and things. But can we learn anything about our asthma phenotype from reaction to biologic? For example, I tried Dupixent but had a bad reaction. Does this mean the particular mechanism of the biologic wasn't the right one for my phenotype?
Yes, I think it's a great question, and I will be disappointing you because I don't have the answer. But I think it's good to, well, the reason that I picked this question is that I really appreciate the importance of the question behind it. How can we predict anyway how a person will respond to a specific biologic or other treatments. And so far, we are not that good in predicting for an individual patient how the response will be. But we learn more and more. Every year we learn more. And also, and that's the reason why I would like to say this, we learn about things because many of the patients with severe asthma and using biologics are joining in their own countries in registries or in SHARP, which combines registries from several countries in Europe, but also this will happen outside Europe. And I think I'm really grateful for every patient who is joining in this registry because, well, in the Netherlands, we ask patients every 3 months to give us answer to the questions on their app. And, well, they must be tired of all our questions. And again, the same questions, same things again. But that's the way we learn more and more how to do it best for the patients. And so it's maybe not the answer you hoped I would bring, but I think this is really good to realize that you are really, really important in bringing the answers.
Thank you very much for that, Annika. Ratko, are you wanting to ask any of the questions? Can't hear you.
Sorry, the usual mistake. So there were a number of questions related to treatment that didn't involve drugs. So we heard from Rolf about how this is done in altitude. I'd love to be able to send my patients to you, Rolf, but unfortunately, that is not possible. I suspect around the globe that's also not possible. But there was one specific question about exercise, which Reno, you responded to briefly in the chat line, and the question was, can people who are not overweight, can they benefit from this treatment? Would you, not from treatment, from exercise? Would you like to elaborate a bit?
Yeah, it's an excellent question. I have to say that I don't have the answer yet because we haven't looked at, but it's a good question to see whether the improvement in ACT, ACQ, and AQAQ is depending on the BMI at the beginning of the treatment. So I think in our study, we limited the patients with BMI below 35 because we were a bit anxious for those who had the BMI above 35. But well, my prediction would be that it's also good for patients with BMI below 25. So I think normal weight, because my belief is that it's the improvement in the general health status of the patient that make the patient feel better. And I'm thinking especially on the symptom of dyspnea, probably, and also maybe chest tightness. I don't know. We haven't made an analysis on the detailed symptoms, but it was the. But my prediction would be that it's also useful in those patients with normal weight, for sure. Yes.
Yes, I think evidence from various centers that have an interest in this is emerging, that it is helpful right across.
Yeah.
The thing that I'd like to add to that is that it has a good impact on our general well-being, on the state of our mind. If we exert ourselves, we feel better. There's always a little bit of an endorphin rush, and it doesn't have to be, running like a maniac, through the woods. Even a gentle stroll, being in nature, is good. It addresses things like, it gets us away from pollution and so on and so forth. And the final thing I wanted to say is that if we look at the COVID experience, the best protection that one could give oneself was to be fit, was to be, walking a certain distance I think it's equivalent to 150 minutes per week, which dramatically reduced the rates of admission into intensive care, even if the patient was overweight. So there's a general effectiveness of exercise, and I would encourage all asthmatics, absolutely all, even the most severe asthmatics, to get out, and enjoy some form of physical exercise.
Thanks. So there's a couple of questions that I've seen that kind of can merge together to ask Luciana, Maya, and Karen. So there's a question was about where could patients find more information about the different phenotypes of asthma, but then leading on from that, how do we advocate for ourselves about the best treatment without undermining the professionals? So I guess that comes from, where do you find the information, and then how do you put that information to your clinicians as well? It'd be great to hear from all of you if that's possible.
Yeah, okay, I'll try to be as short as I can. I think you can ask, the patient can ask the specialist, of course, if he's lucky enough to go to the multidisciplinary center. There are websites, Patients Association, that can give that kind of information. You can find a lot on the websites, on the GINA documents, on the sites of IFA, ELF and ERS themselves. But let me try to steal 1 minute. I think that we are all tackling with different aspects of the problem of severe asthma, but we are missing the umbrella one, and is basically how many of the patients that have severe asthma are treated. I know many may have them, but we don't know how many they are treated. For instance, in Italy, I think only 14% of severe asthma patients get the right treatment. So I think that we could possibly aim to a joint effort between ELF, ERS, IFA, the local patient association, for the immersion of the patients. And the immersion means sending them to the multidisciplinary centers. So make a kind of promotion, but let those centers be known by the patient association and whoever can, because otherwise we have a lot of people that remains without the proper treatment. I remember an IFA study in 2019, probably, about the delay in diagnostics, and it was taken throughout Europe, 700 patients, and the delay in diagnostic is minimum 3 years and maximum 10 for the severe asthma. And that's my primary concern as a patient association. Let them come up, let them get properly diagnosed and get the proper treatment, where in the multidisciplinary centers that they do not know where they are and that they exist. So we need to solve this problem first. Sorry, I was a bit longer.
No problem at all. It'd be great to hear from Karen quickly, and Maya as well. Just
yes, he almost said it all. I just want to add that this multidisciplinary team, it would be fantastic if they also thought about all the things that are caused by asthma, like osteoporosis because of too much cortisol intake, Addison's disease, diabetes. At the moment, well, I've got them all, but there's no one who can tell me when I need to do what, because the pneumologist looks at my lungs, the endocrinologist looks at my hormones, but it's always very yeah, the Addison's disease and my asthma, they react. If I've got a low cortisol level, then I can have trouble breathing, but that could be just because of my Addison's disease. And I can have muscle pain and joint pain because my cortisol level is low because I'm having an asthma attack. And there's no one to help me, no one to look at it. So yeah, those are, and I hear a lot of people here who have the same problems. And to be honest, it's the first time in my life that I've met other people with the same testimonies like I have. So it was an eye-opener.
Yes, I think that's going to be a key takeaway actually from today, is about the sort of the.
Can I answer to that?
Yes.
The thing is, with the current healthcare system in all countries, you have different specialists, like you say, and ideally you're looking for somebody who basically controls it all. And I do know from personal experience, because the things you say, we see here a lot. However, I am a pulmonologist, like you said, but then I think the key is to see what you know yourself and how you can help a patient, and have short lines of communications with other specialists who sometimes when somebody's here for 8 to 10 weeks, then I say, is it okay if I call your internal medicine doctor, your internist, and then you can really try to how can you say that, shorten the distance and see if you can help you in your situation, basically. And also, what we do in the program is tell patients about all these different aspects. But in my own experience, sometimes when patients don't have these problems yet, it's really hard to reach them, basically, because they only see the benefits. But unfortunately, in your case, when you do have a couple of the complications, then it's key to find all the specialists and bring them together, I think.
But I just want just quickly say, those specialists, they have, well, you can see them every 6 months for 10 minutes, and that's it. And when do you see them? You're not necessarily having an attack at that moment. So you just have to explain everything when you're there, and you deal with all the trouble at home, because you can't reach them when things are going wrong. I mean, my endocrinologist, I can write a mail and he will call me on a Wednesday and try to deal with it. But yeah, it's very hard to get into contact. And yeah, I talk with my mom, and we together what could cause it and what is the best way to deal with it. But that's not the way it is supposed to be, I would think, because in that way the doctors don't really understand what my situation at home is.
Yeah, so it's quite a tricky one. Luciana, where you've got your hand up, are you able to pop into the chat what it is that you're wanting to say, just because of the interest of time, so Maya can give her perspective on the sort of advocating without.
So I've been quite forceful. I'm quite ballsy, so I get as much information as I can, and I arm myself with it, and I'm very insistent. I'm very lucky in the sense that when I was pregnant, I made sure the consultants that were looking after me spoke with my asthma consultants, because for me it was really important. To them it sounds bad, but I know I'm just a number, and I'm one of many patients. So the only person who can really get what I need is me. So I arm myself with as much information as possible. And when I'm having that conversation, even if it is just once a month, I'm making sure I've made it clear that I want them to communicate. And I am very lucky that my team definitely do that. And I've got a contact, my specialist asthma nurse, I've got her on an email and a text message on a phone. So if I need to speak to somebody, I let them know. I then don't abuse it. So they know if I've messaged, they need to get back to me. If I don't need them, I generally just see my GP. But even my GP is very good at knowing that I know my body, and I know if I need steroids or antibiotics. then they give it to me, usually without seeing me, because I can tell you if I need anything else. And I know the process. I've made sure that my consultants explain the process of everything. So if I have an exasperation and it's only a certain type or it's not that bad, they tell me which route to go down. So I arm myself with everything. If I know that somebody needs to talk to a different consultant, I make sure I put them in touch. I'm a little bit forceful with it.
It's fantastic. Fantastic to hear that you're so confident in what you're saying is the way to, I think.
I think I'm all fed up of being palmed off over the years. I kind of just, I run with it now. And yeah, I think I've had it for a long time. So I'm a little bit more forceful than I probably should be.
So, Ratko, were you wanting to sort of say something before we move to a break?
No, I think we're 10 past the hour, so maybe, yeah.
Yep. So, yep, if we move the break, if we come back at 20 past still, so it's just a slightly shorter break than we were going to have for our final session, that would be great. Thank you.